Welcome back. 6:15 on your Wednesday morning, and more now on the UCP legislation draft obtained by the Globe and Mail, which suggests doctors could soon work in the private and public sector at the same time. Dr. Braden Mans joins us this morning. He is a former Associate Chief Medical Officer and has studied the impacts of allowing private interests into the public system. Dr. Mans, we always appreciate your time. Thanks so much for doing this. And I guess if we can just start with your main concerns and sort of how you see this playing out if this legislation did get passed.
Thanks for having me. And let's be clear, there are problems in healthcare, wait times in the emergency room, not having enough family doctors, long waits in search for surgical services. And that's why we've seen the government make this announcement. The problem is that this announcement is not going to fix the problems that we have, which is long wait times. It's actually going to increase wait times in the public healthcare system. If you need cancer surgery, it's going to continue to increase your wait times for that. And it will reduce wait times for people who are able to pay, who have got a credit card that can cover the costs of services.
We hear arguments, Dr. Mans, that this type of system is working in Denmark and other jurisdictions. What does the research tell us about that?
Yeah. Whenever there's a story like this and I make a comment, I get blasted by, this is not U.S. healthcare. There's lots of systems that have a parallel private system. Denmark, the UK. UK is a good example, actually. And what's been forgotten in all of this is that the UK didn't decide in the 80s or the 90s that they were going to improve access to, surgeries and MRIs by creating a private system. In 1948, when the National Health Service started, doctors revolted. They didn't want to become salaried employees. They didn't want to be part of socialized medicine. The trade-off was that they came in as salaried employees, the specialists, but in exchange, the system allowed them to continue working privately for about 10 to 15% of their time, carefully regulated. But over the past 20 years, as they've starved that system for resources, more and more people get insurance so that they can use the private system. So we've got a clear two-tier system. Quebec has, the same thing. That Chayuli Supreme Court ruling in 2005 forced them to create this parallel private system, but with major differences to what Alberta's proposing. Doctors either have to opt completely out of the publicly funded healthcare system or they stay in. And we've seen a tripling of physicians opted out and charge whatever rates they want. Quebec has the lowest or the highest number of people without a family doctor, and it has not fixed their wait time problems. And now they're retrofitting their system to adapt to the problems they've created.
And Dr. Mans, as you alluded to in your first response, there are some important issues that need to be resolved, especially around wait times in this province. So if we're not looking at that as a solution, where should the attention go?
Well, again, there are evidence-based solutions. So we need an overarching plan that covers the entire system. We actually need a healthcare workforce plan so that we have the doctors and nurses we need to be able to do, the surgeries that we're talking about. The reason that we've got this big problem is we don't have enough operating room nurses. We don't have enough anesthetists. So when you get your surgery done in the private system, you're taking a doctor and an anesthetist with you as well as the operating room staff. And so they're not available in the public system, which is why we've seen with the chartered surgical facilities, wait times have not gone down. You simply have changed where the surgery is happening, and there's fewer surgeries being done in the hospital. We're having trouble staffing the on-call rosters in hospitals. So again, the solution is actually getting physicians more organized as groups, bring them together, central access and triage, single wait lists, so we don't have thousands of wait lists in the province. Every doctor now has 2 wait lists. They're going to have a 3rd with this for-profit surgery.
Okay, and we haven't seen, obviously, the legislation yet. We'll continue to watch this, and I'm sure we'll have you back to talk about it, Dr. Mans. Always appreciate your time, and thanks for your insight.
You're welcome.